Thank you so much for coming, first of all, and sharing this time with us. My name's Chris Diefenbach. I'm an orthopedic foot and ankle surgeon. I will give you, I'll give you a rundown of kind of my history, my training and everything. I've been with the Rock for a little over a year and a half now. I actually did part of my training here. I did my fellowship training here at the Rock. It's a combined program with UC Davis and the Rock, and so now I'm a part of teaching as part of that fellowship program. We're going to talk about bunions today. This talk specifically this is the first time I'm giving this one, and so I appreciate feedback that you may have at the end of it, like information left out, things like that. We'll have a time for questions and everything, and so please give me your feedback. I like to update these talks as we go, and so I want them to be as useful for you as possible. So starting just a little bit about me, I'm from the East Coast originally. I'm from New York originally. I grew up in high school and college in Pennsylvania. I went to Penn State for undergrad. I went to NYU for medical school and did an intern year at University of Colorado in Denver, and then did my residency at University of Pittsburgh at Hammett Hospital, which is up in Erie, Pennsylvania. And then came here to Reno and to Sacramento to do my fellowship for foot and ankle training, specifically in orthopedics. And then I went on to practice at Flagstaff, Arizona. I was there for roughly 8 years. And I just somewhat recently came back to Reno and joined the Rock, and it's been fantastic, and I'm really happy to be back. I have a wife and kids, and we love the outdoors. It's what we love to do, and so that was part of the draw to come back. And also, the Reno Orthopedic Clinic is a fantastic place to practice and take care of patients, and so I wanted to be a part of that and be a part of the training program that we have here. So let's get started. I don't want to keep us from the bunions too long. So I have a picture up here of turnips. So bunion is, the root of bunion comes from Greek for turnip. And you can see the comparison, right? So we'll try and cover some objectives here. By the end of this, we should cover all of these pretty thoroughly, but please, we'll definitely have time for questions if we don't. So what is a bunion? How does it get here? What are some signs, symptoms? When does it become a problem? Usually, when it becomes a problem, but we'll go through some things that really stick out. And then what can be done? Conservative options versus surgical options, and we'll kind of go through those and talk about them pretty thoroughly. So starting with, what is a bunion? We think of this as kind of this bony prominence or this big bump that we have on the inside of our foot, right? And it's painful or maybe not painful yet, but it's a big bump that's most people don't like. What this really kind of the underlying problem, and we'll go over this, touch on this over and over again, is actually the transition of this bone here. This is called your first metatarsal. As it starts to come inward, it drifts inwards, and the toe starts to drift towards the other toes. And that process is called hallux valgus, okay, or in layman's bunion, okay? And so it's the combination of those things happening that actually kind of creates this. And what we see externally is the bump, or the result of it on the outside. So I do want to go through just some basic anatomy with this. And so just to try and get us all on the same page, the first, sorry, my laser doesn't work real well with the screen, so I'm just going to use my hand to point, okay? So the first metatarsal is this bone here, okay? The first MTP joint, metatarsal phalangeal joint, that's this right here. We're going to talk about these structures quite a bit, okay? The proximal phalanx is this one here, and then you have these two little bones that look like little chiclets underneath the first metatarsal head. Those are called sesamoids. Think of those as a kneecap under your big toe, That's actually what you put weight on. They're inside of a tendon, okay, that attaches to the end of the toe. And so as a bunion forms, those sesamoid bones start to drift towards what we say laterally, but they start to drift this way as the tendon's bowstring on the toe. And that's one of the kind of factors that really kind of is involved with progression of the deformity, okay? And so if we see on the left side, we have nice neutral alignment. The sesamoid bones are underneath the first metatarsal, and we call this neutral alignment. For hallux valgus or bunion deformity, we get drifting of the first metatarsal to the inside. The toe goes towards the other toes, and the sesamoids start to drift this way. And there are lots of variations of this, but this is kind of the framework of how a bunion kind of develops and progresses over time, okay? There's a lot of factors that go into it. There's a lot of, right, we all live very complicated lives, and there's a lot that goes into it, and it's not all, you know, did I wear high heels one too many times? Or did I, you know, fit my foot into cowboy boots that didn't fit appropriately, and that's what gave me the bunion? There's a lot of different factors involved. One of the main ones is genetics, okay? And so 60 to 90% of bunions have a genetic component to them, is kind of the best research that we have on that, okay? And so there's definitely a strong inherited component. A lot of people come in and they blame grandma for their bunions, right? My grandmother or my mother had these had these gnarly feet, and I inherited that. And there's some truth to that, but it's not all grandma's fault. And so it's really multifactorial, nature versus nurture, things like that. It's a combination of the two, really, okay? Tight shoes, high heels, really anything that's trying to force your foot into a position that is not completely natural can definitely influence this. We don't necessarily say like causation is a little bit different, but it influences it for sure. There are other inherent things. So, and this is part of the genetics, where some people have more laxity in their joints, and that kind of predisposes to developing a bunion. Some people have flatter feet, that also predisposes to a bunion deformity, and that's part of the genetic component to this. You can also have traumatic bunions, so you kick you know, a coffee table really hard and it tears the ligaments on the inside of the toe, and then you have, all of a sudden you have a bunion deformity. That can happen as well. You can also have kind of arthritic bunion, so the joint starts to wear out, but it wears out not congruently, or kind of on one side more so than another, and then the toe starts to kind of move to the inside. And so lots of different factors, and there's typically not just one, okay? And then once it starts to form, there are components, and that can be external like shoe wear, but also internal like the pull of the tendons that progress the deformity over time. And so the natural history of a bunion is that it progresses over time. We can't predict how fast or how severe it will become, but we can say that most likely it's going to progress. Okay, so some signs and symptoms. You're all here, so you're interested in this, and you may or may not have direct experience with this, but you can develop pain, swelling, redness over that bump. You can also kind of develop it in other parts of the foot, because as this progresses, you start to distribute weight differently. And so you can start to have, some people actually have more pain in other areas because the big toe is not doing its job. You get some difficulty with shoes, calluses. Some people develop wounds. It progresses to that point. Overlap of the toes, stiffness, transfer pain. You know, those are all things that really are kind of a little bit further on the end of the spectrum of progression. And that's when we start to really talk about, you know, is conservative option really solving the problem at this point, or do we need to talk about other things? I will say, and I'll kind of repeat this a few times, cosmetic bunions that are not painful, we don't talk about surgery for, okay? And so it's really kind of, once you start to develop these symptoms where it's interfering with daily life, that's when it's really becoming a problem. And so if it's starting to limit your activities, the types of shoes you can wear, if you're getting kind of recurrent like bursitis, so bursitis would be right over top of the bump, you can develop this like bursa or like big callus that pads, essentially your body's trying to pad that area. That can get inflamed. You can get skin breakdown or wounds. You can also start to get progressive arthritis because of the deformity. And ultimately, it's a problem when you say it's a problem. So how do we evaluate these? Okay, there's a lot of angles and things like this up here, but I'll try and kind of piece through this pretty quickly. So history and like how did the bunion form is really important. Is this, just kind of part of the foot shape and it's progressing over time? Is there a traumatic component? Is there an arthritic component? It's really important because it changes our treatment options and how we think about what we need to do about this. Is it impacting the range of motion of the joint? The overall alignment, we measure all these things, but really it's kind of we're looking at the big picture. What kind of shoe wear or shoe wear changes have you made or not made? And then we want to look at particularly weight-bearing x-rays. So when we don't do weight-bearing x-rays, it really doesn't show us what's happening when you're walking and when you're using your foot. And so we get a lot more information from weight-bearing x-rays. And we also have to look at other things, right? So if there's some arthritic change, occasionally there can be kind of like inflammatory arthritis, which would be like rheumatoid arthritis or a different autoimmune condition or gout or things like that, right? And so the MRI on the other side, MRI is not kind of a common imaging modality we use for bunions, but sometimes it's warranted based on the history, okay? And then we also want to look at this joint here, okay, which corresponds to this joint, because we can see laxity or arthritis on that joint, and that impacts our treatment options as well. And I'll get into that when we start talking about surgical options. What are our goals with this? We want to relieve pain, first of all, relieve pressure, which usually relieves pain, improve the comfort of kind of just using your feet, right? And so shoe comfort and function. And if we're lucky, if we can, we want to try and slow progression of this. So a lot of these conservative options that we'll go through are basically aimed at trying to slow progression and just make it more comfortable. So some of the more kind of simple methods, right? We start off with shoe modifications and shoe changes, right? So in general, a wider toe box is really helpful. It fits kind of the foot shape better, particularly when you have a bunion deformity. But you can kind of see how different shaped shoes, right, can fit or not fit a neutral alignment. So this fits great when your toe's already kind of bending over, but it can also kind of add to the progression of that deformity, right? So we just need to look at shoes, and ultimately it's what shoe is comfortable for you. But typically wider toe box shoes, a lower heel so that the foot's not, the heel's not raised quite as much, takes a lot of pressure off the ball of the foot and can help kind of slow progression. Supportive soles that are not quite as flexible tend to be a lot better for this, both for pain, but also just for supporting the foot. And so something with a little bit of arch support in it, with a little bit of a stiffer outer sole. So I wrote on here, newer trail shoes. A lot of the newer trail shoes are really good at that because they have that stiffness built in to the outside of the shoe. For typically for trail running, doesn't mean you have to trail run in them, but they're very supportive and tend to be very helpful for this. They also tend to have a fairly wide toe box. Then areas where you can remove pressure, so you can use pads to kind of pad areas. You can also use them to try and offload areas of high pressure. There's a wide variety of spacers and sleeves that you can use for your toes to help control the position of the toe, but also for padding. I typically direct people to just search on Amazon, honestly, for that, because there's such a slew of options, and not the same thing works for everybody. You just need to find what works for you. Typically, it's some trial and error. And then we already kind of touched on the avoiding kind of the high heel type shoes. Orthotics, braces, injections. So my 2 cents on orthotics are that, number one, they have to be comfortable. Your orthotics need to be comfortable for you. If you get orthotics, they need to be comfortable. Your foot does not need to adjust to the orthotic. That's not really a thing. They need to be comfortable for you. Also, there's not just one orthotic that's universally best. And that goes for custom orthotics as well. Just because it's custom made does not mean that it's the best thing for your foot. And so it should be supportive for you, and it should be comfortable. And if it fills those criteria, then it's working well for you. Taping and night splints, these can be helpful for preventing progression. I just have these sleeves up here as kind of an example of something that can kind of pull the toe over a little bit. Typically, those don't work very well when on everyday use. They can work well at night. And if they're comfortable for you, great. Some people don't tolerate it. It's really individual. Occasionally, injections. In general, we don't really talk about injections for bunions. For bursitis specifically, sometimes it can be helpful, but for bunions in general, not so much. When there's an arthritic component, that's when it can really be helpful. Physical therapy, there are some things that can be done with physical therapy. And so, I have some patients come in and are kind of surprised to hear that. But there are actually like toe exercises that you can do that, number one, kind of maintain mobility. That's one of the key things. But then also working on strengthening certain muscles and stretching others. And so this is a kind of a rough diagram, okay? There's a muscle on the inside of the foot that attaches to the end to the toe that actually pulls the toe in. You can strengthen that muscle. It's hard to do, and usually it takes a little guidance to learn how to do that. But you actually can strengthen that, and you can stretch these muscles and the tendon there. And so that can be helpful. Once you have a certain amount of progression, that tends not to be all that useful anymore, but it's definitely a good place to start. We get into kind of anti-inflammatories, topical anti-inflammatories. Those can be helpful. It decreases inflammation, and so it can be helpful in that sense. It's not reversing anything. And then, we also talk about activity modification, kind of avoiding the things that do hurt until that becomes an unreasonable ask. So once we kind of exhaust those options, we start to talk about, is surgery going to be helpful for me? So if you're still having persistent pain is really the big one. Otherwise, if you are in a situation where you're developing a wound, that's also an automatic reason for considering surgery. If you're having limitations on what you can do, what you like to do, your foot should not be limiting what you can do. And if that's when, as surgeons, we really want to try and help you at that point and let you know what we might be able to do to improve that situation. The basic kind of principles behind fixing a bunion, okay, is it kind of revolves around a few things, and there's lots of different techniques in doing this. And so the underlying thing is we need to realign the bones in some way. If we don't realign the bones, anything that we do with the soft tissues or otherwise is not going to be a long-term solution. It's going to come back, okay? So the underlying alignment of the bones really kind of needs to be addressed for it to be a long-term solution in terms of the correction of the deformity. Then we can balance the soft tissues around that and try and restore the mechanics of the foot. like I said, there are many different procedures for correction of a bunion, and it's multifactorial and based on kind of what the underlying problem and cause of the bunion is, whether there's arthritis involved. And so the specifics really depend on your specific situation. Okay. Now I'll kind of get into some of the procedures, and I'm going to touch on these a little bit lightly, again, because there's a lot of different options, and no two kind of patients and no two deformities are the same. And so I can't really give universals, but I'll give you as much information as I can. And I think a really good way to kind of categorize these or separate them in how you think about the procedures is motion sparing or joint sparing, and then joint fusion. Okay, and when do we consider, so nobody likes the idea of fusion, right? Like nobody really likes to hear that, but sometimes it is the best option. When do we consider fusion? It's typically when there's significant arthritis or a lot of the pain is coming from arthritic pain, okay? And then laxity or instability of the joint. And so if we don't feel like we can restore stability of the joint without a fusion, which is getting the bones to knit together, okay, then that's when we consider a fusion. Otherwise, we're really trying to do motion sparing or joint sparing procedures, okay, and I'd say that's pretty universal. Most people want to do that. So some of the more common ones here, I have, distal metatarsal osteotomy is bolded, okay? So that procedure is where we're making a cut in the bone here and shifting the bone over. And I'll have other diagrams to explain it a little bit better. But again, trying to do that to realign the bone structure in a more neutral position. The other one that I have highlighted is a lapidus fusion, okay, which is where we are, let me go back to show you an X-ray. We're realigning this bone and fusing this joint here and here, okay? And those are, I would say, probably the two most common procedures for addressing a bunion deformity. And again, there's different indications for each one. If we're correcting with a lapidus fusion, that's what this image is depicting on the left side. So this is before and after, okay? Too much instability and some arthritic change at this joint, we're able to realign that bone to a more parallel position with the other metatarsals, and then we fuse this joint in that position and do some soft tissue correction here to get the toe nice and straight. Okay. What I will say about the lapidus procedure, where we're fusing this joint here, is that joint is not meant to move a whole lot. So when we talk about joint sparing or joint fusion, losing the small amount of motion in that joint doesn't really change much in the term of everyday function and mobility, okay? Why don't we wait till the end, and then I'll take questions from everyone. And then on this side is another fusion option of the MTP joint of the big toe where the bunion was, and fusing that joint. And we do that universally for bad arthritis at that joint. So if you have a bunion deformity but also bad arthritis, that's the procedure that typically we'll recommend. Again, motion sparing. So this is a distal metatarsal osteotomy. Okay, so we make a cut in the bone here, shift the knuckle over, and we get overall a straight alignment. This looks, when it's first done, fairly extreme on X-ray, but the bones heal together. You can see that it's kind of, it turns into almost like you're guiding growth with like a tree, right? And now the position is nice and straight, and we haven't affected the motion of any of the joints. one of the kind of like buzzwords now is minimally invasive. Just about any of the procedures that we used to do for bunion correction, we can now do minimally invasive. I wouldn't say all of them, but most. All that means is how big is the skin incision? The actual procedure that we're doing is exactly the same. Okay, so like this procedure, this was minimally invasive. And again, we're doing a lot of work inside, but it's through small skin incisions. And so that's all that refers to. Okay, it's not minimally invasive in terms of the trauma to your foot. It's just minimally invasive in terms of the skin incisions. And so you can see the kind of the before and afters here. This is also. So in terms of, and I'm sure we'll have questions on the surgical options, but I did want to try and get through kind of like general recovery times and post-op care and things like that. And then we can talk about any of these points more. So the overall, the recovery timeline, and I will say everybody is different, it's individualized, but early on, so the first, we'll say 6 weeks post-op, we're trying to protect you and trying to allow the body time to start to heal, right? And so that's based on the procedure. We'll limit or have, potentially no weight bearing, but limit weight bearing for the first 6 weeks or so. Sometimes it's just protected weight bearing in, say, a boot or a shoe. But we're trying to protect the work that was done so that your body can start to heal it. After that point, we're starting to get some bony healing, and then we start to transition slowly around 6 to 8 weeks. Usually I tell patients 2 months, we're starting to transition back to regular shoes. At that point, we're progressing activities and doing things in regular shoes, but avoiding kind of impact or really extreme activities. I will say, I don't have it on the slide, starting basically at 2 weeks, I personally start physical therapy. So I have you start with motion and getting moving and doing everything, even though you may not be walking on your foot yet. Okay. And then in terms of full recovery, like when could you get back into sporting activities and things like that? Usually that's somewhere in the range of starting at 4 months or so. Occasionally it's as early as 3 months. We have to talk about risks associated with this, right? Anytime we're talking about a surgery. So in general, all of the procedures that we use to treat bunions are very successful at pain relief. Okay. The risks that are associated with it there are some that are common, some that are uncommon. Uncommon are the severe things like infection, wound healing problems. Okay, we really want to try and specifically avoid wound healing issues, nerve issues. We know where all the nerves are, so we try and avoid the nerves. Things can happen during surgery, but there are very rare occurrences. More common things are like stiffness. Okay, we can't control how the body scars, and so scar tissue can really affect motion and stiffness. And then recurrence of a bunion. So almost universally, a portion of the deformity comes back. And that's considered recurrence. What we think of it more as is, did it recur to the point where it's symptomatic? And that is a fairly uncommon occurrence. And so recurring to the point where it's symptomatic again is less than 10% across the board. And it really depends on the procedure, but that amount of recurrence is not common at all. Let's see, and I'd say again, yeah, I think kind of the individual risk is higher in somebody who has, say, a soft tissue condition that leads to more scarring. That person, I'm going to counsel that patient a lot differently than I would counsel somebody who's never had any issue with scarring with surgeries before. So how do we choose the right option? We go through a thorough evaluation with history, exam, x-rays, as we talked about. We definitely try all the conservative options possible, and make sure that none of them are working well enough to achieve what we need to achieve. And then we discuss the goals of what we want. What do we want to get back to? What kind of function do we want? What kind of pain relief? What are the top 1, 2, and 3? What am I trying to get out of this? What's the recovery like? And I like to tell people that, like, if you can't do the recovery the right way, it's really not worth doing the surgery, because the recovery is what gets you the best result from the surgery, right? And then if you still have questions or you don't feel comfortable, it's always okay to get a second opinion. Any surgeon that you're talking to should not have a problem with you getting an opinion from somebody else on, what they think is the best option for you, right? So I guess some take-home things, and then we'll get into some questions. So bunions are very common and treatable. Conservative treatment typically relieves the symptoms, but does not correct the alignment. It doesn't correct the underlying problem, but it can treat the symptoms. We resort to surgery when pain and/or function are limiting the things that you want to do, and conservative care has failed. And the decisions that we make for that are very personalized and individualized, and you can't follow one algorithm for everyone, because not everyone will be happy with that. So this is just my information, and then this website here is just a really good website for getting any information on foot and ankle conditions and treatment options. And they have some kind of patient experiences and videos and things like that on there as well. It's just a really useful site. So I think at this point, I don't know. Yeah, at this point, I'll take some questions. Yes. That's a great question. So do you need a referral, or can you just make a MyChart appointment? I believe that that question is best answered by your insurance company. And so, yeah, based on insurance, I would say most commonly at this point, I think that you can make those appointments, but I would check with your insurance first. Yeah. So yeah, so if you've been seen at the Rock in the past, you can make that appointment through MyChart, and we can get the referral from your primary for that. Yeah. Yes. Mm-hmm. 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 Yeah, great question. So the question was, if conservative management options don't solve the problem, and we know that a bunion typically progresses, what is the point of waiting, essentially, right? Why not fix it early, as soon as you start to develop a bunion, if you know that conservative management is not going to reverse it? It's a great question. Ultimately, I think the answer is really weighing risks benefits. Okay, and so it's going to, again, I keep saying this, but it's going to be very individual. But what my counseling is that, if it's not interfering with those things, if you can get different shoes and it's okay, that's much easier than recovery from a surgery. and it's not worth the potential risks associated with the surgery at that point. If you're at a point where you've done that 3 different times and now you can't find a pair of shoes that make it comfortable to hike, you're in a little bit different arena at that point. And it may be worth it to you to undergo a recovery from this. Foot and ankle surgery is a hard recovery because it affects your weight bearing and everything that you do. And if it's your right foot, it affects driving. And so it's just all these things that you have to take into account. And so I wouldn't say it's like, I think you could think of it that way, but you really need to take into account what the recovery is going to be like and what your goals are essentially. And, you know, it's progression, I guess, understanding that progression does happen, but is it going to progress to a point where you absolutely need surgery later? We don't know, and I can't tell you. So I guess that's kind of how I would think about it. Yeah. Sorry. What if we have bilateral bunions and need both feet done? Okay, good question. I try to urge people strongly not to do both at the same time. You can, and you can try and do one recovery, but the recovery is much harder. So in general, you do at least have a period of time where you have to be off your foot to give it the rest that it needs, and to be off both your feet is really hard. And so I do think that when you do both, you compromise the recovery on both to a certain extent. In the long run, is that going to change your ultimate outcome? Maybe, maybe not. It's hard to say, but I do think that it changes how you recover acutely, and that can affect the long-term outcome. So I try and avoid it. Sometimes it's not avoidable, and it's really the way that you need to do it, and it's possible to do for sure. But I try and say pick the worst one, and we'll do that first. The other reason I really try and encourage that is because then you know what the result is, and if you like the result, we can replicate that. And if you go through all that and you don't like the result and you don't think it's worth it, then you know that ahead of time and you haven't wasted your time on the other foot. But again, it's really, yeah, it's personal. It's a personal choice. Yes. Is there an age cutoff for surgery? In general, I would say no. No, I would say there's no age cutoff for surgery, because we're living longer and we're living longer actively. And I've operated on elderly patients a lot, and they can heal just as well. And it's really, I think that's a balance of overall health, because right, biological age is different than chronological age, right? And so you can be 80 and very healthy as opposed to 50 and not healthy at all. And I would much rather do the surgery on an 80 healthy patient. And so I don't think that there's really, nobody has a strict age cutoff. It's just a discussion of why are we doing this and how dangerous is it for you? And can we do this safely, and can we get you through the recovery safely? Yes.
Brands of shoes.
Yeah.
Especially athletic style. I
still
wear, that's 90% of.
Yeah.
But there's some, if you get a wide one, it looks like Herman Munster shoes. And then there's certain brands I know, like I won't wear Adidas because to me Adidas.
Okay.
But are there brands that you would say without? Yeah, I know you're professional. So you can't say, well, you should buy the John Jones brand, but you could say that maybe you're made a little bit wider just for this type of stuff.
Yeah, absolutely. So are there better or worse shoes or brands of shoes? And I tried to keep it broad based on, on the previous slides and said those new trail shoes, right? So yeah, I'll tell you some brands. I don't have any affiliation with any of the brands. But what I typically recommend to people are, and they may or may not be kind of what you're looking for in terms of like, right, like what you see, right, exactly, appearance or dress shoes or not whatnot. But some of the, like Hoka, I think does a good job. Ultra does a good job. New Balance, Brooks. And then I have a lot of patients that really like Skechers. And I think it's more the flexibility. It's not because they're such a wide toe box. Those other brands have a really wide toe box, most of them, and that's why I recommend those. But I think Skechers have a really flexible material, and that's why they're comfortable for a lot of people. But that's by no means an exhaustive list at all. It's really just kind of the way that those brands trend is they have a nice wide toe box and they accommodate your foot well. Yeah. Yes. Mm-hmm. Yeah. So are orthotics helpful after bunion surgery? I would say in general, yes, because they're supportive and we want to support the foot. And so I'd say for the same reason, I would recommend inserts of some sort. Again, the type doesn't matter so much. It needs to be comfortable and supportive. But for the same reason, if you're supporting your foot, it's in general going to be better for your foot. And so whether that's part of the recovery immediately, usually when as people get out of the boot and back to regular shoes, I kind of encourage either an orthotic or just an arch support of some sort to try and help with that. But I would say, yes, it is helpful. Yes.
But your surgery is invasive, so no more pins in your toe.
No more external pins. Yeah, so I say in general, yes. It's strictly a bunion surgery. I would say I personally don't use external pins. There are other procedures that are very commonly done with a bunion surgery that sometimes require pins. I really try and avoid pins if possible, but that's a little bit of surgeon dependence. So it's kind of training and what they have found to work the best. I really try to avoid external pins for risk of infection and just people don't like them. They're painful. But I will say as is a little bit off topic, but for lesser toes or like hammer toes and things like that, there are a bunch of different options and none of them work perfectly. And that's why there's a lot of different options. And pins do tend to be, that's kind of the old and reliable and true option that yeah, it's true. But occasionally we do still have to do that sometimes, but not for a bunion. Yeah. Yes. Mm-hmm. Sure. Sure.
Your skin being thin, which bruises easy as you get older. This aging thing sucks.
Yeah. So does bone density affect healing essentially from the surgery? So I'll just say, osteopenia or osteoporosis, bone density. No, it doesn't affect bone healing. Yeah. It does affect fracture risk, right? And some of the secondary things. So I would say it's not like we don't think about it or we don't care about it. We absolutely do. And we'll protect you probably a little bit longer because of that. But it does not affect the bone's ability to heal itself is not affected by that. And so if you're not being treated for it at the time of surgery and it's something that comes up, I would still recommend treatment for it, but not to heal from the surgery. And I would also say it does kind of affect us surgically while we're doing the procedure. And so it's helpful to know. And so I would definitely notify your surgeon if that's if they don't know about it, because it is helpful to know going into it. But it doesn't affect healing. Yeah. There's somebody in the back. Yeah. Yeah, absolutely. So can you slow the progression without necessarily reversing it? And the answer is 100% yes. Okay, so you can slow the progression by supporting the, we'll say, neutral alignment. Okay, and that's, you have to do it using external means, right? So the shoe wear, spacers, sleeves, things that help keep the toe in a more neutral position, the physical therapy exercises to try and work on the muscle and strengthen the muscle, those things can absolutely slow progression because you're not constantly stretching that joint into a position that it essentially wants to go in. And so you can, but we just have not found that you can reliably reverse it using any. There are a lot of claims out there for different things that can help reverse it, and none of them have actually been tested and tried and true to show that externally. Yes. Uh, yeah. Yeah. So do you need how can you get a PT appointment for that? You would need a referral. So if you see, but I would say there's no reason that can't come from kind of any physician that you're seeing. Yeah. Yes.
I just wanted to make a recommendation for this. It's a good question.
Yeah.
What brands of shoes? The Asics Gel Shoes.
I know about those.
Makes a 4E in all the hand sizes. That's what I would.
I got them.
So the gentleman over here just said Asics Gel Cumulus
Yeah.
will make a very customized wide shoe, right? You said it's off the shelf.
Well,
You said it's 4E.
yeah, you have to order it
Okay.
from Asics because they don't carry it.
Gotcha.
Stores.
Okay. So I'll add Asics to the recommendations. Thank you. Yeah. Thank you. Yes.
Thank you very much for this presentation. I think very informative. I would myself would want to take the approach to be more conservative due to the fact that I'm very stingy about my time and doing whatever I want to do, be out there and have all kinds of fun. But I also want to take care of what's going on with my feet and my little stick out bunion.
Yeah.
My big toe going over to the other toe and kind of like take it over in its space. So mentioned the conservative and was looking at the x-rays.
Yeah.
I haven't really seen really doctors about this.
Mhm.
So, or specialists. So if I said I would like to approach more conservative, so physical therapy, do like some sort of not off the drugstore wall,
Mhm.
the brace, more
Mhm.
of a higher level one,
Sure.
because I don't know, but over time that would get that bone to shift
Mhm.
because it got shifted by bad shoes. Yes, I was a girl who wore heels,
Mhm.
and we had to look good. And the nice little shoes. Would an option like that, and how long would you feel your patient should consider to see if there's going to be some sort of correction to
Mhm.
make that toe go back a little bit.
Sure. Sure. So can you make subtle progress on your bunion deformity with conservative options, even customized conservative options? Yeah. What I've seen is, I mean, I know we've said, no, you can't reverse it, right? What I've seen is that if you institute some of the, say you have a bunion deformity and you've started to get, now it's painful. I have seen patients do some of the conservative things with, say, a sleeve or a spacer, something that helps pull the toe over, supports it. I've seen that significantly improve pain and like inflammation, right? So swelling, things like that, improve function, let you, hike without pain maybe. And so you'll see that improvement. When you're not using it though, it tends to just go right back to where it was and start to cause the pain again. And is it the next time that you hike? Maybe not, but in 2 weeks, maybe it probably will. And so it's not a permanent reversal. And so you can see progress with it, but you have to continue using those conservative options on a daily basis to continue to see that improvement. If you think of it as like you're just using an external method of trying to correct the deformity, right? And so if you lose that external method, you're not correcting it anymore. And so you will see a decrease in the pain and inflammation potentially, hopefully, but it's going to be dependent on using that method. But again, I haven't seen any study of any of the external conservative options that actually have a sustained benefit after stopping their use. Does that answer your question? Okay. Yeah.
Was trying to do it, saying the option, I'd like to take that conservative method, apply it with that, with some sort of supports and physical therapy combined.
Yeah.
Would that help strengthen those ligaments and everything? Saw your little thing there.
Yeah.
Up in there and,
I
may slow down the progression.
Absolutely. It would, if you combine different conservative options, and I would recommend that you combine them. It's not just one or the other. You're right. You don't have to pick. You can do all of them. Yeah, I mean, I think you can absolutely slow the progression and help it. You can. Yeah, of course. Okay. Yes. Yeah. Mm-hmm. Mm-hmm. That's a good question. So essentially, I guess the question is, what's that? That's typically called a hammer toe deformity. When you get that in the lesser toes where they curl up like that, do you get a hammer toe deformity because of the bunion? And loosely, the answer is yes, you can. It's not the only reason that you can get hammer toes. You can get hammer toes without a bunion. But a bunion does influence the other toes, and it can lead to getting a hammer toe deformity, particularly the second toe tends to be common. And that deformity of the other toes can continue to be flexible, or it can be rigid. And it's kind of a secondary thing that we do see very commonly go along with a bunion, yes. Okay. Okay, let's do 2 more, and then in the interest of time, we'll do 2 more, okay? We'll go with you, and then you'll be next, okay? Yeah. Yes, please. So, okay, so I think you bring up a good point. So the question is, did the bunion cause the pain I'm having on the outside of my foot? Yeah. And indirectly, yes, it can. So the bunion forming increases the width of your foot overall, and then makes it harder to fit inside shoes. And then you can start to press on the outside of your foot and have problems associated with that. So yes. That becomes a complicated thing to talk about, because do you then ultimately it becomes, do I fix the bunion to fix the other problem? And that's a hard thing to answer. Sometimes the answer is yes, and sometimes it's no, but that's a clinical decision that somebody would have to answer. But yeah. Yeah, and I would say like those brand of wider toe box shoes will be really helpful. The other thing that I didn't bring up on the slides is, and it used to be much more common when we used to have people that worked on shoes or modified shoes, right? A cobbler, right? You don't really see those much anymore. You can still find them sometimes for like leather shoes or like cowboy boots, but you can stretch the material. So you can actually get a shoe expander online and stretch the material of the shoe, put the shoe expander in the shoe, and it can stretch it in a very specific spot. And so you can do that. Okay. Yeah. Yeah. Okay. Last question. So driving after right foot surgery. Typically, I would say, and this is very surgeon dependent, but for me, I typically will say, even though you're still in a boot, between 2 and 4 weeks. And it's based on how you feel and how your foot feels, and making sure that it's responding to what you tell it to do, it's behaving. You can't drive with a boot on. Okay, so you have to remove the boot to drive. And so even if you're not putting weight, like we're not allowing weight bearing on your foot necessarily, you may be able to use it to drive. But it really depends on how your foot feels. And I would say that that's, again, very patient dependent, and just how you're doing in your recovery. Yeah, so you can drive before you're out of the boot, but you have to remove the boot to drive. Welcome. Okay, well, thank you so much for coming.